All right. Hello, everybody, and welcome to the third annual SHE CAN Storytellers event presented by First Horizon Bank. My name is Grace Ashew. I am the Director of Community Programs at CAN Community Health. A little bit about CAN Community Health. Our mission is to empower wellness through inclusive sexual health services. I am very excited to welcome you all today to such an important conversation regarding healthcare and the scope of women's health regarding the services that not only CAN provides, but other community members and practices, much like yours provides. Today's event is designed to spark meaningful dialogue and education around HIV and STI prevalence within the female community, particularly amongst women of color. Through storytelling and shared experiences, we aim to foster understanding, reduce stigma, and also promote health equity. To begin, I'd like to welcome our presenting sponsor, First Horizon Bank, and invite Senior Vice President Maureen Hagarty to share a few opening words.
Thank you, Grace. Good morning. I'm Maureen Hagarty with First Horizon Bank. It is truly my honor to welcome you to the Women Transforming Healthcare event. Today, we unite not just to champion HIV advocacy and equity, but to ignite hope and action in every corner of our communities. Our storytellers are more than speakers. They are pioneers, visionaries, and warriors for health justice. Their passion and courage are a powerful reminder that when women come together with purpose, barriers are broken and lives are transformed. At First Horizon Bank, we stand beside these remarkable leaders. We believe that advocacy and compassion have the power to reshape the future for every person seeking a voice and a chance at a healthier tomorrow. First Horizon Bank is committed to providing financial support of approximately $25 million distributed through the First Horizon Foundation in 2025 and 26,000 service hours by our employees. We are also committed to bold ideas and actions that build bridges in our communities. This event is your invitation. Listen deeply, learn fearlessly, and let these stories move you to action. Each of us has a role in playing in creating positive change. Together, we can accelerate change and push the boundaries of what is possible. Thank you for being part of this journey. Today, we rise stronger, braver, and more determined to transform healthcare for generations to come. Let's get started. Let's make history. Thank you.
Thank you so much, Maureen, and thank you so much again, First Horizon Bank, for all of your support of CAN's mission, as well as our Susan Terry Foundation's mission. So thank you so much for being here. We appreciate the wonderful words and a great opening. Moving through our program, I just wanted to highlight the impact that not only women of color, but women as public health leaders have made in this sphere that we are all working in as a community members. One of the things that I'd really like to highlight is our distinguished guests that we have today that are going to be presenting and answering any questions, taking any conversation points from this call and beyond. Our first panelist that I'd like to welcome today is going to be Asal Sayaz, Director of Governmental Affairs at AMFAR. Welcome, Asal.
Hi, thank you, Grace. Thank you for having me. Really excited to be part of this important dialogue today. My name is Asal Sayas, and I handle leading policy efforts and government affairs at AMFAR, the Foundation for AIDS Research. Thank you.
Thank you so much for being here, Asal. Up next, I'd like to welcome Dr. Marissa Robinson, founder and principal consultant of Real Health Impact, LLC.
Hey, everybody. Welcome into this space. If you're here live or you're watching the recording, it is such a pleasure to be here. Again, I am just excited to engage in this conversation. I have my own consulting firm, so I really focus on health equity and centering Black women's health and also women's health in general. And I have several years of expertise in epidemiology, infectious disease, and specifically HIV. So really excited. Appreciate First Horizon Bank. And then, of course, CAN and Grace for all of her tenacity and her leadership of getting us all here today. So excited to jump in. Thank you.
Thank you so much, Dr. Robinson. Up next, I'd like to welcome Dr. Oni Blackstock, founder and executive director of Health Justice. So welcome, Oni.
Good morning. Thank you, Grace, and good morning to my fellow panelists. Also, just echoing Dr. Robinson's appreciation to you, Grace, and your organization, and to First Horizon for supporting this really important panel. So I'm Dr. Oni Blackstock. I'm a primary care and HIV physician, researcher, and public health leader, and I'm founder of Health Justice, which is a health equity consulting and research organization.
Wonderful. Thank you so much, Oni. And last but not least, I'd like to welcome Holly Figueroa, Tribal Liaison.
Nakwang talongva, na Holly Figueroa pahan matiwa, na talaw manamahupi matiwa, na atawangwa, askwale amayasa yakam yaf itamam tupalti. Good morning, everybody. My name is Holly. I am from the Hopi Nation here in Northern Arizona, and thank you for joining us this morning. I'm really looking forward to the conversation today and the learning from my co-panelists here, and just really excited to be here. In Indian country, we are unfortunately in public health crisis in relation to STIs. And so really looking forward to having some conversation about that and seeing how we can work together to address this really important issue. So thank you for being here, and looking forward to our conversation this morning.
Wonderful. Wonderful. Thank you so much, Holly. And thank you. All four of you wonderful leaders have not only developed in your communities, but also beyond, and have taken the work that you do and have moved the needle forward, especially for our women of color. As we know, the incidence rates are climbing when it comes to HIV and STI prevalence rates, especially amongst our Black women, our Hispanic Latino women, as well as our Native Indigenous women. So I can't wait to just dive into our conversation today. And our first questions are going to actually be for Asal specifically. Asal has a plethora of background when it comes to governmental affairs, policy, and advocacy. So Asal's questions are going to be centered around what ways that we can educate ourselves when it comes to governmental affairs. So Asal, your first question is, as federal policy shifts and has significantly impacted the HIV landscape, particularly through funding cuts and program eliminations, can you speak to these effects and changes that are altering our community-based organizations working in HIV and prevention care?
Sure. As far as federal affairs, I think one thing that it's really important to note is that this current administration, what we're seeing as far as policy is very conflicting as far as HIV from Trump 1.0, from his first administration. During the first administration, he rolled out the ending of the HIV epidemic. So ending the HIV epidemic by 2030 was a plan that they rolled out with HHS. And it was first focused on particular states and counties. And now what we're seeing, what most recently came out this year from the president's budget, was proposing cuts to that very program that this administration first launched. And so that is hugely problematic, as far as also withholding funds, federal funds, from being dispersed to community organizations and NGOs. I think that when we look at federal policies, and there's a wide array that will impact people living with HIV, particularly women living with HIV, Black women living with HIV, and in communities of color. One, we have to think about Medicaid and the One Big Beautiful Bill Act that we saw passed earlier this summer that will that cut billions of dollars to Medicaid. We're seeing Medicaid work requirements instilled and proposed in various states, and that will harm people being able to get uninsured. And we have to remember that Medicaid is the largest insurer of people living with HIV. Outside of that, right now, as everyone knows, we're in a government shutdown. And prior to the shutdown, Congress was working on appropriation bills, federal funding bills. A lot of the funding that gets appropriated by Congress that goes through whether CDC, Ryan White, this all gets funneled back to the community, to CBOs and NGOs. And so having those services is really critical to having sustained federal HIV investment. When we saw the House pass their bill, and that is the GOP bill that they have passed the House, that gutted over $1.5 billion for HIV services. It nearly gutted CDC's HIV prevention program, cuts to, I think, over 500 million, don't quote me on that, but around that, to Ryan White. Now, what we saw in the Senate was different. The Senate, while they had some cuts, maintained a large portion of the HIV funding. The House bill went past what even the White House had proposed. And so we saw Congressman Mark Pocan from Wisconsin introduce an amendment trying to restore this funding in the House bill. However, that was unfortunately voted down by party lines. And so it's really, really important as we're looking not only to the impact happening right now, because we know that we're seeing staff shortages, clinic hours reduced, and this is really important for whether it's awareness, testing, wraparound services, that we ensure that we're protecting HIV funding for the future. As soon as the government reopens, these federal negotiations will continue. And it's really important that our voices are heard so that we can minimize the harms that will be done to our communities.
Thank you so much, Asal, for that in-depth picture for us. I think a lot of our community members and partners who have joined today are really going to take back this information to learn how best to not only advocate for themselves, but also advocate for the agencies that they work within, which brings me to the next piece of this question. How have these shifts influenced service delivery, access to PrEP, and broader community engagement, especially in underserved populations? Like you mentioned, just the tangible effects that certain things have happened and taken place regarding funding cuts, but tell us a little bit more when it comes to accessibility.
Sure. So I think a lot of these NGOs and CBOs and our community partners already operate on razor thin margins. And so when we're hearing of freezes or curtailing of programs, that impacts outreach, that impacts mobile clinics, and they're operating, because they're operating on federal grants, we're seeing them have to cut some services, case management, patient navigation. And so all the gains that we've seen in HIV, testing, prevention, and treatment, we're going to lose that ground. We're going to see new infections. We're going to see delayed diagnosis. And this is really going to impact, and oftentimes when we see these policies, it's the most marginalized in community that have the greatest impact and harms. And so there's a lot of uncertainty.
Absolutely. And just sharing a personal anecdote on my end, just being in epi and surveillance for the past couple of years prior to my time at CAN, you can definitely see tangible effects when it comes to how it affects women of color. One of the things that I wanted to note is as a woman of color, as many other women of color that I work with or are around, family, friends, we don't always have those tangible accessibility opportunities when it comes to doctor's visits, preventative opportunities. So these things are very important for us to have. And not only just for women, but for other communities as well. So thank you for such a great in-depth answer, Saul. Going into your next question. Yeah, go ahead.
Sorry,
No, go ahead.
Say that culturally competent care is really important because we know these systems that were not built for communities of color and women of color, particularly Black women. And so ensuring that there's sustained funding for culturally competent care is so important. So thank you, Grace, for all the work that you're doing.
Absolutely. For your next question, Asal, as a female leader like yourself in governmental affairs, please tell us more about your role at AMFAR, as well as the importance of advocating for women in these healthcare spaces surrounding policy and advocacy. How do more women get involved?
Great. I think that, historically, even during the height of the HIV epidemic and historically in HIV, women's voices haven't been front and center in the HIV epidemic. And so, one of the reasons I joined AMFAR was really to ensure that women's voices are front and center of the HIV epidemic. I mean, 1 in 5 diagnoses are amongst women, and disproportionately, the burden of the disease is with women of color, Black women, immigrant communities. And so it really is, and I look at my amazing colleagues here on the screen, and I think they're a lot more equipped, given their backgrounds, to talk about the amazing work that they're doing, particularly in the community. But I would say, women's healthcare is currently under attack, and it will take all of us to ensure that we're fighting and advocating for our rights. I mean, even when we look, there are implications for women living with HIV, for example, that men don't have to worry about. Having an HIV diagnosis increases your susceptibility to cervical cancer. That's an implication that we have to think about. And so having that lived experience and ensuring that our voices and our concerns are primary at the center of the table is really important.
Absolutely. And this is why conversations like today are so important. And the information that you're able to share amongst each other and beyond that is also going to help propagate the notion of what we're discussing today, but also just in general for women's healthcare and the sphere that we're working in public health. It's so, so important. Thank you so much, Asal. Those were great answers to our questions. Moving on to Dr. Robinson. A lot of Dr. Robinson's background is especially within public health, but also focusing on our priority populations, such as Black women. Dr. Robinson, as a leading voice in women's health advocacy, how do you see the emotional and psychological toll, particularly the constant flight or fight mode affecting Black women outside of traditional healthcare spaces?
Well, it's all kicked us off and gave us a really great landscape of how all of these things impact us as an ecosystem, right? But this fight or flight response truly is killing people, and stress is killing people. And if you can think about a diagnosis and thinking about medication adherence, that might be the very, very, and I mean literal, very, very last thing on your mind in terms of what you have to deal with in a day's time. If you have to feed your family, if you're a caretaker, a mother, or you're caring for loved ones, if you have a multi-generational household, if you're thinking about transportation, housing, there's all these social determinants of health that obviously impact how we live each and every day. And then when you combat that with the rising costs of everything under the sun and all of the government shutdown ecosystem and how it is somewhat trickling down to so many people. I think in past years, folks who have experienced a government shutdown, I feel like, oh, it's going to be okay. You know, we have fail safes. We have the balances of government. We have all of these things that are checks and balances. But this is a little bit different because it is much longer. And then so many things have been exacerbated before we even got to the shutdown. And as Asal already stated, thinking about this fight or flight response, that is a constant vigilance that women in general have to have. So you're thinking about being a caretaker, but you're also thinking about, okay, this hyper alertness is actually impacting our overall health. And that level of cortisol in your body and the levels of stress are actually killing us. And so there are several pieces of literature that have been peer reviewed, that have been published, New York's best time sellers, that have talked about this being a huge issue within the community. And so ignoring it is not the answer, right? And a lot of what we see is that we're ignoring science, we're ignoring medicine, and quite candidly, we're dismantling a lot of systems that we have relied on in our infrastructure for so long. And so I think when we're thinking about disparities, when we're thinking about inequities, we can't turn a blind eye to the flight or fight response. And the fact that so many women in this current environment are literally so stressed out that they can't even fathom taking medication or thinking about their own health because they're worried about so many other things and the systems that they're a part of.
Absolutely, Marissa. And one of the things that you mentioned that I thought was very important is social determinants of health. If you think about it, sometimes healthcare falls to the bottom of that totem pole, especially when it comes to housing, transportation, nutritional services. Those are things the everyday person needs to access to even receive care. So thank you for highlighting that. The second part of this question is, how have recent social and political events influenced the way Black women navigate care? And what shifts are needed to better support the well-being and access for Black women?
Yeah, so this is a great question, and I think it is very pertinent to what we're seeing, specifically when we're talking about the current elections that are happening tomorrow, and then the midterm elections that are happening next year. It is so important that if you are not registered to vote, this is just a shameless side note, that you need to register to vote. That is your right, and that is something that I think voter registration is something that is also being politicized and is also being attacked. So in thinking about our brown communities, our Black communities, our communities of color, it is so important to use your voice. And a drop in the bucket may seem small, but when you have a drop in the ocean and there's multiple drops in the ocean, you can make a storm. And so thinking about your small individual impact in that socio-ecological model of me as an individual, and thinking about the connection to the system and the entire, election series, I think it is connected. And for many of us, maybe folks haven't voted or don't believe that their voice matters, or they're being attacked in so many different ways and they don't like what's going on. And I think centering the lived experience around who's at ground zero of these conversations, going to the town halls, going to some of these community meetings is so important, so that we can hear what our community members saying, because what we see in the media is only one story, right? One side, one vision, one viewpoint. But when we're talking to community members, they might have a completely conflicting or a completely different opinion. And so I think as we're talking about recent social events, we have to affirm persons of lived experience, full stop. No matter what that lived experience is, is it lived experience of living with HIV, or living with sickle cell, or living with a health condition, or is it someone who has lived experience who's on government assistance, for example, because we were this weekend, we were talking about SNAP benefits being, stopped. So that was a huge conversation that I think many of us on this call were familiar with from our different landscapes that we come from. And then just thinking about how we shift from the individual experience to a community experience. When we talk about failed public health messaging, in my, I'm also a GW adjunct professor. And one of the things we talk about in my class all the time are some of these unintended consequences. And then also this impact of how we fail in public health all the time, and how we can use these failed practices or challenges to create best practices and learn from our mistakes, but not reinvent the wheel. And some of what we have learned in the past is that some people are very selfish, right? We're a very selfish community in the sense of society-wise. And so when you say a public health message that it's going to protect others, that goes in one ear and doesn't even come out the other, because nobody hears you, because you're talking about other people. And when somebody's selfish, they're worried about self, literally. So when we're framing some of these messages, we need to say that this is going to impact you. And this is to save you. This is to help you make better informed decisions and promote better health and wellness. So I think in totality, we have to normalize rest. We have to normalize honest and open conversations. Hello, right here. And then we also need to figure out, with healthcare delivery and with the political and social climates, how are we all going to work together? Because it's going to take innovation. We can't rely on the old systems that we've had, because they're being literally erased as we're on this call. And we know that emotional safety is at the top of our concerns and needs to be addressed. So I appreciate the question.
Of course, that was a beautiful answer, Marissa. Thank you so much for such a detailed answer, especially regarding that socio-ecological model. I think at times we forget that individualism is important, but as a community, how do we function together is also very important. For your second question, Marissa, how can community-based organizations collaborate with local female stakeholders to influence change and address often challenges and nuanced experiences within the HIV care continuum? Because as we know, one patient is very different than the other. So how can we bring that together a little bit more?
Yes, so we know that we are not monoliths, no matter what population you're talking about. And so it's really important that we center a lived experience at the beginning. So if we're thinking about an intervention, an initiative, a program, we have to bring folks from the community that have that lived experience at the beginning, not as an afterthought, not in a focus group after we're done. We need to have them at the table, right? And we need to bring them along, and also do that feedback loop. So whenever we're done, whatever we are doing, intervention or not, we can also bring them along to what were our findings, what were the conclusions, and what are we going to do next? Because maybe the funding has stopped, or maybe the grant has ended, or there's other, circumstances that happen. But I do think that feedback loop of centering lived experience is paramount to what we're doing, especially in the infectious disease world. We can't have programs and think that we're doing a great job and pat ourselves on the back when nobody of lived experience was at the table when we created them. And I think when we're talking about, I think Asal already mentioned it, that in public health, a lot of folks, especially women, were not in the center of a lot of these conversations when the HIV epidemic specifically started. And so now really reframing how we talk about, risk to reasons, and not saying things like risk, or using stigmatizing language like infection or infected, like really changing how the HIV landscape and the infectious disease landscape, and ultimately the healthcare landscape, and how we talk to people, with people, and then cultivating that trust, that shared leadership, that shared accountability model, and also figuring out if we don't get it right, that's okay. And it's okay not to be okay, but what are we going to do after that? And really making those conversations pertinent at the beginning, and not as an afterthought, or not as an oopsie, or really taking that accountability of, hey, we thought this program was going to be really great because it was free. We had folks of lived experience at the center of it, but unfortunately we missed the mark. So what are our lessons learned, and how can we be better for it? Because I'm a lifetime learner. I don't know about anybody else, but I'm a lifetime learner. I'm always like, oops, okay, that didn't work. Let me go over here and just try something different. But that is the beauty of public health, right? We don't always have all the answers, and we're trying to find them, but really coming together as a community and having that trust, that shared leadership, and making sure that persons of lived experience are at the center from a community-based organization standpoint, all the way up to federal, and all the way back down to folks who are service delivery and service receivers. We can do much better together than we can in silos and separately.
Absolutely. And Marissa, I'd love to just give you your kudos for a minute, because you are one of those individuals who, if someone doesn't have a seat at the table, you pull a seat up for them. So I think that's a very wonderful trait for yourself as a leader, and even beyond that, extending that to all the other ladies on the call too. So thank you so much for such a well thought out answer and information that you provided. Going over to Dr. Blackstock. Dr. Blackstock, we have 2 questions for you as well. Can you share a little bit more about your role as a public health leader during your time at the New York Department of Health? What key insights have you gained regarding the impact of HIV and STIs in your work?
Sure. Yes, and I'd like to just start with a quick little story that leads into this. It was like in 2017, and I was a physician researcher working in academia, doing a lot of HIV prevention and treatment research. And I think I was like getting a little bit like frustrated at the pace of research. How it was so slow, and I was trying to recruit participants actually for this group visit intervention for Black and Latina women. And I was just feeling like kind of disillusioned and discouraged. And I was just like checking Facebook, and like I get this message from one of my colleagues and a fellow HIV advocate, Terry Wilder, who's like, Oni, they just posted for the assistant commissioner for the Bureau of HIV position. We need someone like you. We need one of us in the role. And I was like, oh my gosh, no, I'm a researcher and a physician. I had 2 other people on my team. And I think and I was like, okay, fine, I'll do it. And writing the cover letter was really easy. And the funny thing, again, how the universe works, I had shadowed the person who was the assistant commissioner for the Bureau 7 years before as part of this leadership program. And I remember thinking, Dr. Monica Sweeney, and thinking, she has such a cool job. She gets to do a lot of stuff like out in the community. She gets to do a lot of like programmatic work. And so it was just sort of like, it was a 360. So just to say, if for folks who are watching, particularly folks who maybe earlier on in their careers, like if an opportunity comes, just know that you're worthy of it. Because I had some doubts. And I basically went to leading a team of 2 other people to leading a bureau of about 350 people with a $200 million budget. And a lot of that funding, as Asal mentioned, a lot of the funding that we got as a health department came from the federal government. And we bid it out to the community-based providers and health providers and non-clinical providers to give services, provide services in the community. And so just to say, I come to this work, particularly in public health, thinking about HIV not just as a medical condition, but as a social condition. And I honestly can't think of one medical condition that has such a disproportionate impact in certain communities. Like here in New York City, 90% of new diagnoses are among Black and Latina people. When we look at, same gender loving men, trans women, cisgender women, like all these communities that are just consistently impacted, and realizing it's really sort of the system sort of producing expected outcomes, because we know the system disadvantages certain communities and maybe advantages or provides access to resources for others. So I came with that perspective. And so it was really important for me to center equity in the work that we were doing, particularly, so health equity, but particularly also racial equity, in addition to LGBT equity. So we want to make sure we were centering our trans community members. So some of the work that I was really proud of that we did, for instance, was creating these organizational capacity building grants. And so they were basically, we found that, we'd hear from trans-led grassroots organizations or Black same-gender loving men-led organizations that would apply for our funding, but because they were much smaller, couldn't afford maybe a grant writer, they were much less resourced, they often were not able to score high enough to get funding, public health funding from the Department of Health. And so in talking to community members, our team at the health department was like, let's just turn it on its head. And so why don't we give funding to help organizations sort of build their foundation, like build their infrastructure, their basic processes. So getting funding for like creating a board, or getting funding for developing a budget. And so we did that work, and that's work that I'm so proud of. We also extended that to micro grants for smaller community-based organizations that didn't necessarily do HIV work, but did work, because as we know, HIV is really, again, as I mentioned, a social condition, and it's related to housing, to structural inequity, to lack of access to healthcare, all of that. And so we made sure we found organizations that were providing support around housing, that were providing job employment. We connected with them as well, because we know that HIV is a distal outcome from those larger social and contextual and structural factors. So I was like incredibly proud of the work I did. I will just say this, like I remember, the person who sort of I reported to was like, we need something really sexy for, really something new, exciting, and the health department had done the Place Shore Network. We had like all these really sex positive ads throughout the city. And I remember thinking like, all this is great. And we were continuing it. We continued with Living Shore, which was focused on transgender and cisgender women and raising awareness around PrEP. I was like, that's sexy, but I was also like, racial equity is sexy too. And so what I wanted to do is make sure that, when our funds went out, often our funds did not go to organizations that were led by people most impacted. So that some of that work that we did around the capacity building for MSM and trans-led organizations was about making sure that the funding that Asal had mentioned that comes from the federal government, that we're responsible for bidding out and for distributing to community-based organizations, that goes to organizations that have leadership that's reflective of who is being most impacted, that's in the communities of who's most impacted. So I would say like that was part of my legacy there.
Yeah, I love that. And you obviously have a very outstanding legacy as well. And the second half of that question as well is, what opportunities do you see for advancing prevention and care within female communities of color? Like you mentioned, tying in that racial equity lens, but what other marketing or potential collaboration opportunities do you see?
Yeah, I think, when we think about HIV, and I think particularly, we know obviously our trans sisters are incredibly impacted, and also Black and Latina cisgender women. I think it's been a little bit of a nut to crack, a hard nut to crack with cisgender women, because the reality is, and even to a certain degree for trans women, a lot of it's about contextual and structural factors, it's about these larger factors. So like trans women, because of exclusion from, many different employment opportunities, sometimes trans women have to engage in transactional sex. Same thing with cisgender women. So it's a lot of times it's people are sort of created, they're placed in situations where they are made at risk versus something else. So we need to like recognize that. I would also say that I think what I learned is that like a multi-stop sort of bundling everything together for women is really important, for cis and trans women. So HIV, I think, is maybe, I think Dr. Robinson had said, maybe the last priority for folks. And that's totally understandable. So what do people care about? Like, what matters to you? What are your priorities? What's going to resonate with you? What's relevant to your life? So again, wrapping PrEP into that. So whether it's like you're going to you're a birthing person, you just had your baby, and you're going to a breastfeeding or chest feeding meeting. How do we include PrEP into that, into like lactation visits, into home visit programs? So for me, a lot of it is really about how do we just ensure that what we're trying to put out there aligns with what community members see as priorities, because otherwise there's going to be a huge disconnect. And we try to do a lot of work, actually, when I was at the health department, around intimate partner violence and PrEP, and integrating, getting our community providers to do some screening around intimate partner violence, using a model that wasn't like, tell me if you've been hurt or whatever. It was actually about health. We know that healthy relationships affect people's health. It can lead to like good health. And when people are in unhealthy relationships, that can also have a negative effect. And sort of like normalizing and saying, here's some information about PrEP, about HIV testing, and we're going to give you some information to also share with a friend, and like let us know if you have any questions. So again, like just trying to normalize these different interventions.
Absolutely. Normalizing the conversation is so important. Like you said, I would love to see a PrEP education or PrEP referral opportunity during a well woman's exam. I think that would be a wonderful idea. Lactation centers, like you mentioned, I think those are wonderful ways to incorporate important conversations such as this with just the general population. And before I jump into your next question, Oni, one of the things that I also wanted to mention is specifically just kind of talking about sexual networks when it comes to women. I don't think we often talk about sexual networks and how those propagate potential, not risk factors, but maybe just some factors for women to consider when it comes to their health. So that's definitely important when it comes to Black women, Hispanic women, and also other women of colors, to consider how are we engaging in those sexual networks, and how are we providing that education for ourselves and also for the others that we engage with. So I think that's where we kind of tie the knot between intimate partner violence, associated health risks, etc. So perfect.
No, totally. And I wonder if I could just respond to that. And I totally appreciate that point you mean, because I think what we realize is these larger structural factors, even something like residential segregation due to redlining from more than a century ago, that pegged communities of color as higher risk, so it was much harder to get mortgages, and these communities ended up being divested in sort of from an economic perspective. And we know that what that has done is 100+ years later, that has concentrated risk in certain communities. So even if you're someone who you're sort of, you think you're approaching things, you're like, I'm trying to take care of myself, I have one partner, I'm trying to do the right thing, because this concentration of poverty also concentrates, STIs, HIV, it increases the burden of many different things. Even if you do have one partner, the risk is the likelihood of having a partner who might have HIV increases. And again, related to mass incarceration, which takes eligible partners out of the community for many Black women. Again, so we have concurrency. For instance, what happens is, instead of people having like sequential relationships, someone might have multiple relationships happening at one time, and that can drive HIV and STIs.
Absolutely. Thank you for that response. Oni, your second question is, can you tell us a little bit more about your role as the founder and executive director of Health Justice? And how does your organization continue to advocate for health equity and educate the general public regarding its mission?
Yes, so happy to. So just to say that, so I was one of a few, just when I was at the New York City Health Department, one of a few Black women or women of color in an assistant commissioner role. It was incredibly challenging. There were so many highs, but there were a lot of lows. And when the pandemic hit, I was leading a bureau of 300 plus people. I was also part of the leadership for our COVID-19, like our city health response. And then my child was doing remote, the school was trying to figure out how to do remote schooling, and it was initially a disaster. So I was like, oh my goodness, I need to get out of here. So I was like, this is like too much going on. And I felt like I had really given a lot. I had given a lot to this work, and we had done some really, really wonderful work. And I don't see it as like an individual, as a really collective effort at the health department, because there were so many just dedicated folks. But I realized I wanted to create a counter space. Like, I wanted to create a space where I could say, these are our values, and this is how we should engage with one another, and how we should be treated, and do work that is impactful and transformative. So some of the work that Health Justice does is we have a dual mission. Part of it is around equity, organizational, and leadership capacity building with other health departments and with other healthcare systems. And this really grew out of the work that I was doing at the New York City Health Department, where I said racial equity, that can be sexy too, because our commissioner at the time, Dr. Mary T. Bassett, who is amazing, she had started a Race to Justice initiative where, really just flung the doors open to really understanding the role of racism and what we need to do to really advance health equity and ensure that all New Yorkers attain health. So just to say, I was doing that work kind of when I was at the health department, but I was like, I had someone who was close to me at the time say, Oni, you don't need to even be here to do this. You can leave and you can get your own company and do this yourself. And so I was like, you're totally right. And so I created Health Justice, and we do virtual trainings and in-person trainings, strategy, technical assistance, organizational equity assessment. So we come into an organization and give them and do some data collection, interviews, focus groups, surveys, give them a sense of where their organization is on their equity journey, and provide an action and roadmap. And then also the other part of it is also, I just created a grounded innovation lab, because I also am a former computer scientist. I was a computer science pre-med major, and really have always been interested in community participatory approaches in all of my research. And with the emergence of AI and its potential to scale a lot of the harms that we have seen AI cause, we need to have community at the table and leading on this, and it's all happening really fast. So that's a lot of what my Grounded Innovation Lab at Health Justice is also focused on.
Absolutely love that. So innovative and so unique in the way that you're able to tie in technology, healthcare, health equity, and tie it all together for agencies that are looking for these opportunities. As we know, those may be far and few. So Oni, thank you so much for the wonderful work that you do. And thank you for answering those questions perfectly. Going on over to Holly. Holly, we have 2 questions for you. The first question would be specific to tribal communities that often face significant barriers to HIV and STI care due to socioeconomic and health disparities. Based on your experience, how have you worked to challenge or shift this narrative?
Well, in our tribal communities, do a lot of work here in Arizona, and we have some really, really challenged communities just based on geography. We have tribal communities that are at the bottom of the Grand Canyon and are in very limited spaces. And we have tribal families who live out where the nearest town is perhaps 2 hours away. So let alone, we talked a little bit about social determinants of health. And as we know, being healthy and in really the importance of nutritional health is, from our younger aged, our little ones understanding just what basic fruits are. They don't know perhaps what a kiwi fruit is, or, they know basic like apple, orange, banana. But, we want to really educate. The overall issue is education in general. I think some of the issues that we experience in Indian country is the lack of data. Data is a huge issue for tribal communities. Our systems are, sometimes tribally funded healthcare systems. Some folks rely on the Medicaid, Medicare systems of care. And then you may also have the Indian Health Services system of care. And then, of course, for our veteran population, you might have the VA system of care. So our healthcare system in general for tribal members is very complicated and confusing in general. So it's always, a challenge in making sure not only are we educating our communities on the different health disparities, but it's also, do you understand the healthcare system and how to access care? We relied a lot on telehealth during COVID for many different health issues, whether it was cancer, whether it was preventional care or primary care. But as we know, some of these programs are now going to be cut out. And so we see a lot of funding issues already. And some of the things that we were able to use during COVID are now being taken back. So some of the strategies that we were getting folks used to are now being taken back. So it's barriers for Indigenous communities are very, the list is long. We also see on the funding end, the lack of funding, especially when it comes to grants. A lot of times our providers, our healthcare systems are not understanding of tribal government structure. And a grant takes a long time to not only write, you need the data, you need the experiences, but just when you get to that point, a lot of folks don't understand that in a tribal government, the process to even be allowed to get the grant submitted takes a long time. So you might get notice of a grant that's available and you might have maybe a month to complete it and submit it. That doesn't work a lot of times in our tribal communities because it has to go to the tribal council process. It has to get approved. It has to get reviewed and approved before you can even submit it. So we saw really, really big funding issues and challenges during COVID. While the country was receiving their COVID funding, our tribal communities didn't get their COVID funding until 3 to 4 months after the rest of the country. So we lost a lot of people during COVID in Indian country. So that is also a really huge issue. We also run into the trust issues. We have that minority stress that people experience in our current systems. We also, like I mentioned, the geographic challenges for testing. We do have some partners. I'm really thankful to CAN community and the collaboration that we've started there. Because a lot of times, especially with county funding, state funding, a lot of times you're limited to certain areas, certain counties, certain geographic areas. So when you have, tribal communities or families that live, like I mentioned, 2 hours away just to get tested, let alone go on to treatment, that is a huge, huge challenge. And as someone mentioned, medication adherence, even getting your, medication can be a challenge. We have some tribal communities that the entire community receives their medication, which is mailed to the local healthcare clinic from Phoenix. And so, we call the pharmacy CVS or whomever the pharmacy is when you're sometimes like you have your last pill or whatever, and hopefully you can get to up the street to the pharmacy. Again, our tribal communities are not that accessible to different things, let alone, housing. We've talked a little bit about housing as well. So, I mean, it's such a challenge to get a lot of these things educated on, because we as tribal or indigenous communities already have a lot of disparities that we're facing. One of the biggest ones as well is already life expectancy. I think our indigenous communities probably have the lowest life expectancy already that they're kind of, working against, let alone you have all the other, maternal health issues, HIV, STI issues, as I mentioned. Unfortunately, indigenous communities lead, this percentages and are continuing to increase right now among our tribal men. And our women are also 2 to 3 times higher in infections amongst higher than our non-native populations. And so where do we start? How do we educate? Who do we start with? Unfortunately, we also have challenge with our law enforcement issues, because, a lot of times the federal and the state law enforcement programs do not have jurisdiction on tribal land. So that's another really big issue. So, we are facing, it's really hard to get, harm reduction. We struggle with harm reduction in tribal communities because of the lack of understanding. And so overall, I think just the lack of understanding when it comes to the conversation about HIV is that, a lot of times people don't understand that some of these the diagnosis, you could still be asymptomatic. So much stigma is associated with it. And so again, normalizing the conversation. Do we have these conversations with our up and coming, our young people? I think a lot of times we need to have these conversations in the elementary school age children, because by the time they're getting to the middle school, we're already seeing, unfortunately, the sexual abuse that's happening amongst our young adult population. We have sexually active young people. And so are we ensuring that these individuals are being educated? But also, unfortunately, we are seeing, some of the multi-generational homes as well. Unfortunately, we see some of those sexual abuse cases happening in those situations. And so, we could go on and on about the understanding, but I think the biggest issue right now is, how do we normalize the conversation, have these conversations in schools, but also in homes? And so we have a really high substance abuse population as well. So you see in our tribal communities, a lot of times the grandparents are raising the children or are still taking care of the families. And so there isn't a lot of parenting happening as well. So we are also looking at increasing parenting, basic parenting skills for families. So I think, in our indigenous communities, unfortunately, there are many, many of these disparities that impact, that impact this topic and important issue of HIV and STIs. Our young girls are increasing in the number of diagnoses, but again, they get tested perhaps, but we don't see the follow through on the treatment or the medication compliance. So those are a lot of the issues and challenges that we see currently in tribal health. In addition to, the discrimination, once for some of our urban Indian population as well, you still have that minority stress, that discrimination that still happens in our healthcare system, unfortunately. So really advocating for that cultural humility in our healthcare system. A lot of times you're going to get folks who are going to go to see a primary care provider, and whatever that primary care provider says is the word. And so there's no patient advocacy, or they don't a lot of times ask follow-up questions. They just, whatever is told to them, that's it. And so again, therein lies the importance of that education, or importance of perhaps having some peer supports as it relates to some of our healthcare disparities. We're starting to see an increase in development of peer supports within our substance abuse populations to address a lot of these issues, because as we mentioned, the people with the lived experiences need to be at the table. They need to be sharing their stories and their experiences. We see that now in our substance abuse populations, but this one here, I just last year was in South Dakota. South Dakota, their tribal communities are leading in Indian country in STIs. And that's not where we want to lead. That's not where we want our pride to be. We really want to make sure that we are able to continue, because one of the things as a tribal liaison that I'm constantly telling our communities, but also our partners and providers, is that for Indigenous populations, we're already losing our language. And that's what makes you Hopi. That's what makes you Diné. That makes you Lakota, is your language and your ceremonies and your songs and stories. Once we lose that, we lose who we are as Indigenous people. When we lose a female, we lose that bloodline. We lose that clanship. We lose that medicine that these women carry, and these elders and people share down to generations. So not only are we looking to those who came before us to continue the teachings of who we are, for me as a Hopi woman, I'm also thinking of the generations that are coming after me. And so there is a deeper meaning to healthcare than really looking a lot of times, the data is super important. The data sharing is important. The treatment and all those things are super important. But for me, my passion, my dedication and commitment is not only to ensuring health and wellness, but it's also ensuring the continuance and the resiliency of Indigenous communities, because that is what makes us who we are. And so it's really important, as I mentioned, cultural humility, that doctors, nurses, psychiatrists understand who we are as Indigenous people, because we're all unique. We have over 576 tribes in the country. Those are federally recognized, and probably about 200 more only state recognized tribes. So, I mean, how many of our physicians understand the tribal communities that they are serving? Here in Arizona, we have 22 tribes, but let alone we have other tribal members who live here in our state as well. So I go to my healthcare provider and I'm like, do you know me as Hopi? What do you know about Hopi? What do you know about, tribal health? And so that is my role, and that is what I take on, professionally, but also personally. I'm very much, we talked a little bit about our LGBTQ Two-Spirit population, very much an advocate and ally for that. And, my relatives now are like, we still have a lot of education there to do. I go out and do a lot of training. And sometimes I'm just amazed at the questions that I get about children playing with other children who perhaps are a little bit more feminine acting than the other. And is that going to rub off on my child?
Yes. And Holly, This is amazing. I think that one thing I was just going to jump in as well
Sure.
when it comes to all the information that you've shared is when it comes to like what lessons that we can take from all the information that you shared regarding
Mhm.
health disparities, social determinants of health, food, nutrition, all of those things. What can another community member or leader take from you who's working amongst the tribal community to move forward with?
Mhm. Absolutely. I think one of the things that I teach is the building of trust. Whether you're a provider in an urban community or you're a provider in a rural community, I would always let them know to make the effort to physically go and talk with the community, follow the understanding of understand what their tribal structures are, what are the things that they do, because I mentioned we're all unique. We have similarities, but we're all unique. And I think the most important thing is that cultural humility and leveling that playing field, because we want to make sure that providers understand who they are connecting with and that they are learning, but also on the other side as a liaison, it's important to have someone who can help build that trust, to help the receiving and receive the information about who they are connecting with in the healthcare system. So it's a mutual relationship building process for both. Cultural humility is the most important because that's going to help build the trust.
And Holly, thank you. That was so insightful and so educational. Being a Phoenix native myself and working with Holly over the past 3 years has been such an enormous, wonderful opportunity for me to not only learn more about our tribal communities, but also to partner with her as well as our other representative, John Canyon, on ways that we could better engage our tribal communities. So Holly's a wealth of knowledge. She is a leader in our community, especially amongst the tribal community. And I just wanted to say thank you for just sharing your openness and vulnerability regarding our tribal communities as well. This actually brings us to the closing of our Q&A session today. I wanted to say wow and thank you to all of our panelists who shared such wonderful thoughts, such wonderful ideas, things to take away. Saul, Marissa, Oni, Holly, you guys are such insightful, powerful leaders. And not only do I look up to you all, but I aspire to be more like you all, especially throughout my journey. And I just wanted to thank you all for being here, sharing your knowledge, sharing your ideas and thoughts. I do have a few closing remarks just to say thank you to everybody who joined us today. So first off, thank you to First Horizon Bank. We appreciate your commitment to CAN's mission, as well as your support of the Susan Terry Foundation. Thank you again to our panelists today for our discussion. All of you women inspire the community for better and encourage access to quality healthcare. Thank you to the Susan Terry Foundation, our foundational arm of CAN Community Health. To learn more about the Susan Terry Foundation, go to susanterryfoundation.org. And our last is just thank you to all of our viewers across all of our platforms. We actually streamed live on Teams. We had individuals on LinkedIn that you saw, Facebook, YouTube. We were able to broadcast this out to so many individuals. So thank you for joining. We've seen your comments. Please find more information about CAN Community Health by going to cancommunityhealth.org to find our locations and services. We will be back with the next installation of the SHE CAN Storytellers very soon. So stay tuned for more information. And thank you so much again. Have a great day, everybody.